Hey guys, in an effort to get out some more ultrasound education in a user-friendly format, we decided to do some clinical cases. This one today is concerns lung ultrasound. Um, I think this portal is easy and hopefully over the next how many years, if you guys have any good cases and save your clips, we can get out some main med specific videos to you guys going over the basics of certain aspects of ultrasound. This one again is dedicated to lung ultrasound. Let us know how it goes, how you like it, and what we can do better with these. This being the first of many to follow. This is a lung ultrasound case. This is a 57-year-old healthy male, relatively young, coming in with a fever and tachypnea and hypoxia. As you can see, he being young and healthy, his heart rate and blood pressure actually initially normal. He came into triage with SATs of 78% acutely, and then we brought him back to critical care. Got his SATs up to 99 with a non-rebreather. Complained of sweats, productive cough, headache, kind of vague viral syndrome complaints over the last few days. He'd actually seen his PCP 3 days before and had an X-ray, which was normal for a cough. This was his X-ray 3 days before. So he came in, and just to go over quickly the zones of ultrasound here. So as you can see, it's hard when you put the probe in the lungs to know where you guys are scanning. So if you can just throw a number on your image in the text, that really helps us when we look at your images. These are the corresponding zones that have been generally accepted. There are different zoning patterns, but this is the most popular. Again, there's 8 zones, 1 and 2, 5 and 6. In general, 1 and 2, 5 and 6 are going to be where you're going to look for pneumothoraces. 3 and 4, 7 and 8 are highly sensitive for pulmonary edema. 4 and 8 are where you extend into the EFAST exam. That'll give you your hemothorax as well as your pleural effusions. So if you put these numbers when you do your thoracic ultrasounds, it really does help us get a kind of a map of where you are. So this patient had findings in essentially every zone. So I'm throwing the probe on his chest in zone 1. As you notice, my depth isn't really deep. I try to keep my depth more shallow with lung ultrasound so you can really get a good look at the pleura. As you can see, his pleura is irregular. Do you see these irregular borders? Normal pleura in a 50-year-old healthy man should be nice and smooth and stable. This is not. This immediately jumps out at you and says something's amiss, something's abnormal. As you see, some B lines as well, which emanate from the bottom contour of this opacity, this wedge-shaped opacity. What I mean by that is that little wedge. That means that there's some focal consolidation there in that lung parenchyma that's abutting the visceral pleura. Here's zone 2. Again, B lines coming from a little bit further underneath the pleural border. As we'll show you in a bit, pulmonary edema B lines are discrete to these type of B lines. These B lines are more associated with a pneumonic process. Again, emanating from lower down. So I'll start shallow and then I'll kind of make my depth a little deeper. Zone 3, so again, if you think of the map I showed you before, this is kind of the right axilla. Here's a definite focal consolidation. You should not see anything here. Lungs should be normal. Normal lungs should be not visible. So if you're seeing something between the ribs, here's one rib, here's another rib. If you're seeing something, then that means that there is an abnormality, and that depends on your clinical context. But here is an abnormality. Again, kind of looks like liver tissue. They call it hepatization. Zone 4, why I know it's zone 4, gain needs to be up a little bit here, but you can see liver here, and the start of the diaphragm down here in the inferior portion. Can't see a ton with this image, in all honesty. This is just kind of a comprehensive showing. Here is a little bit better image. So there's, again, zone 4. Here's your liver tissue. Gain should be up a bit. But you can see the lung here. You should not be able to see the lung, and you can see a small effusion here, so focal consolidated lung with an effusion. Zone 5, this is no mystery. Again, abnormal pleural line, pleural border. So we're seeing it both now on the right, or now on the left. Before it was all on the right side. So this is a diffuse bi-pneumonic or lobar process on both sides of the thorax. Here's zone 6. Again, here's the heart. This is a zone that often the heart kind of gets in the middle of. Here's some B lines coming down, not a ton in this view. Zone 7, a couple B lines. As you see, they kind of come from lower down, not from the pleural surface. This pleural surface is ragged. It's not smooth, as you'll see with most pulmonary edema patients. And zone 8, lastly, the spleen here, diaphragm. Here's your these wedge-shaped opacities just underneath the pleural line. Okay, so to compare B lines, this is pulmonary edema. These B lines are diffuse, emanate from a smooth pleural border. There's no focal consolidations underneath that pleural border, as opposed to these B lines, which are coming from lower down. Here's the X-ray that we got in the ER. Again, both-sided process, diffuse process. Now you got to think of your differential for this patient. Pneumonia review, often unilateral, not always. Skip lesions that we saw with low-lying B lines that we saw as well. Consolidations and an irregular surface. Both pneumonia and pulmonary edema can have effusions. Again, pulmonary edema will be diffuse, uniform, with typically a smooth pleural surface. So again, in this patient that we just saw, we had a bilateral process. Your differential, not looking at vital signs, includes a bilateral pneumonia, viral pneumonia, as well as interstitial lung disease. And what this patient had was a really severe case of ARDS, which landed him in the ICU, intubated for days, trached, and pegged a week later. So which of these following does not support a diagnosis of pneumonia? Unilateral B lines, smooth pleura, skip lesions, pleural effusion, dynamic IVC, or inadequate EF. So think about that for a second. So which does not support pneumonia? So a smooth pleura, right? So smooth pleura is going to be more along the lines of pulmonary edema. All of the other answers here could be associated with pneumonia. We just talked about this. What could mimic ARDS? So ARDS is what this patient had. What could mimic it? Notwithstanding vital signs, interstitial lung disease. Patients with diffuse, long-standing lung disease will often have these bilateral consolidations with occasional B lines. This patient was febrile, hypotensive, and tachypnic. So that is more along the lines of ARDS, but just for your full differential. Just a reminder, sign up for our rounds. There's still some spots available, and we'll try to get some more of these cases out to you and give us some feedback. All right, thanks so much.